It's incredibly frustrating that it mutes.
Right, okay, yeah.
Minimises.
I don't know.
Part of campaign.
Alright.
I know you.
There we go, we're live and there's sound. It's always a relief.
And that's called first. Yes, he was introduced. Have you spoken to him?
I've not been to Scrutiny in about 12 years. Yeah, I used to do it when I used to be kind of 8B, 8D, I always did Scrutiny.
Presentation.
They're not.
Introduce themselves.
She'll ask. Davis text me.
How's that getting on her day in London? She's given any feedback?
I've not spoken to her.
No.
No, I'm sure I'll catch up tomorrow. Are you in Leicester tomorrow? Yeah.
I need if I'm going to see people at distance.
I didn't go.
Oh.
Yeah.
Aside from Theo the Baker, who may be late, we've got everybody we're expecting.
Okay. Yeah. Well, welcome everyone, and welcome to this meeting of the Adult Social Care, Health and Communities Overview and Scrutiny Committee. So I'm Bob Purse, and I'm chair at this meeting. So I've got some things to say, but let's deal with apologies for absence to start with. Richard, you going to tell us that?
Yes, Chair, thank you. We've received apologies.
Can you speak up, please, because you're at the back?
Can you hear me? Is that better?
Yeah, I can hear you now.
Fantastic. Thank you, Chair. We've received apologies from Councillor Eastwood, Councillor Emery, and we've also received apologies from Councillor Simpson, who is substituted by Councillor Ware. Thank you, Chair.
Thank you. And I've also received apologies from Hazlitt member Laura Cummins. So any declarations of interest from members of the committee this evening? Sorry, any apologies, any declarations of interest from members of the committee? Okay, thank you. So we'll go on to the minutes of our meeting, which was held on the 23rd of June. Are they a correct record of the meeting that we can approve? Thank you very much. Right, I've got some announcements to make. So I need my sheet with Chair's announcements, which say, so we're being webcast on the YouTube channel, so do speak into the microphone. We've not got a fire drill planned, so any instructions should a firearm go off from our Democratic Service colleagues. And please put your phones onto silent if you've got them, just so that we don't get interrupted. We've got two public speakers. We've got Jean Lineker and we've got Joe Morris as well. So we look forward to your contribution in a moment. And you've got 3 minutes. That's great, Jean. Thank you. And also Councillor Carley, I think, is coming to speak as well. So that will be good. I just want to say two other things. As you know, the Care Quality Commission visited West Northamptonshire Council during the week of the 18th of August to look at adult services, and I was invited as chair of this committee to speak to one of the inspecting team. So I was able to, well, I spent an hour with them, and I hope I represented the work that this committee carried on over the last year and what our developing work plan looks like for the coming year. And we look forward to receiving their report later in the year and any recommendations that particularly relate to the work of this committee. I just wanted to say something about service user involvement in the work of this committee. The Council's got a strong and developing commitment to co-production, and I think it's really important that we as a Scrutiny committee also involve where we can service users in work that we've got going on, whether that's this main committee when we're looking at items or if we've got any task and finish groups. So I think I'm keen that we should be doing that and hope that members will kind of, if you've got contacts in the community that we can involve, then we do that. And if you can keep me to the mark in making sure when we're looking at items we actually do that, that is good, because it's very easy just for the committee to get consumed with its own business and forget to involve people. So I think I'm keen that we actually do that. So, which brings us to public speakers. So, Jean, would you like to come and address us, please? And you're addressing us on item 6, I think. Is that right?
It's integrated surgery.
Item 5.
5, right. Okay, item 5. That will be good.
Sorry, I'll take this. As you know, I've got no speech. As you know, I've got no speech. No. If I start coughing, don't worry about it, because I've got gastro problems. I'm sorry about that, but the problem is I've got a lump on my breast. I went to a mammogram and they couldn't find it. The problem is, I felt it, but they didn't, not at that time. And what I would like to ask is for another surgeon to be there and feel people's breast or whatever they've got before they get cancer. I had to do 3 lid sleeps and there wasn't an appointment on the surgery that I went to at the hospital. And I was dumbfounded. I had to go back to the doctor every time. And the trainee doctor that was there at Mayfield made a referral. And it took 3 weeks to get there. By then, I might have got cancer. I don't know. But I don't want it to happen to anybody else. That's all I've got to say.
Right. So really, let me just understand that this is really making sure that when you've been to the GP,
When I went to lid sleep,
when you go to the GP,
backwards and forwards,
yes,
each time,
yes,
I'd done a lid sleep. So she said, "There's no appointments."
yes,
each time, and that shouldn't happen.
Right. Okay.
All right.
Yeah.
When someone does a referral, it should take a shorter length of time.
Yeah.
And when you go for a mammogram, get someone there to test women's breasts before they get the cancer.
Yeah. Thank you, Jean.
Earlier.
Yeah.
That's me.
Right. Thank you. Okay. We'll pick that up as we go along. Yes.
Sorry.
No. That's important point, Jean. I think.
Thank you.
Now, Joe, would you like to address us at this stage of the meeting, and then, yes.
And I'll back her up if she wants.
Right.
Sorry.
So, Joe, do introduce yourself and tell us the organisation you're coming from, and you've got 3 minutes.
Okay, so my name's Jo Morris. I am from the Semelong Community Exchange. Jean is one of our service users who comes to our Bellinge hub, so she knows us. I'm not sure if we're in the right place, but I'm just going to read my thing, and at least you guys all know who we are then. So we run community hubs in Bellinge, Leicester Street and Semelong. Everything is free and provided without judgment. Briar Hill is still running thanks to its volunteers. They're doing an incredible job, but they too will need support to keep going long term. On paper, these hubs are simple. It's 1 day a week with 2 staff, a hot meal, some activities, advice, and a friendly place to sit with a cup of tea.
And the quiz.
And a quiz. Sometimes there's a quiz. But in reality, there is so much more than that. For some, it's the only time they leave the house or week. For others, it's where they find support at their lowest point. And for many, it's the one place they know that they're going to be listened to. Now, the numbers. It costs about £13,000 a year to run one hub. To keep all 4 hubs, including Briar Hill, open for a year, it's around £40,000. But that covers everything: meals, staff, activities, support. And for that amount, hundreds of people get somewhere safe, warm and welcoming to turn to. And the impact, it's huge. We've helped people in crisis, including those who felt suicidal. We've supported people with urgent medical needs. We keep an eye on our neighbours. If someone doesn't show up, we notice, we check in on them. One gentleman told us that before the hub opened, he spent every day just behind 4 walls, completely alone. Now he comes every week. He has a hot meal and friends to talk to.
And sometimes empty homes go there.
And sometimes Northampton Partnership homes come. For him, the hub has been the difference between loneliness and belonging. And it's not just about kindness. These hubs also save the council money. People come to us with questions and they get the right advice. This means fewer unnecessary GP appointments, fewer calls to support services, fewer people turning up at one-stop shops when they don't need to. It's preventative work and it's value for money. Even Community Spaces Northampton described these hubs as life-changing and life-saving. Yet, after making that statement, the organisation closed the hubs and we were made redundant. But we've kept them going on our own. We can't keep doing that without support. So my question is simple. Can West Northamptonshire Council help fund Semelong Community Exchange and the volunteers at Briar Hill to keep these hubs open? Because if we lose them, we're not just losing a meal or a friendly face, we're losing a lifeline for some of the most vulnerable people in our community. Thank you.
Thank you very much. Thank you. Are there any questions that the committee would like? Adrian.
Thank you, Chair. There was recently a release for grants. Did you apply for any?
We have only just become we have a limited company by guarantee, so we've only just become able to apply, and we're in the process of opening a bank account, so we will be applying for whatever we can apply for.
Thank you.
Councillor Baker.
There's less restrictions on the warm spaces grants if you apply for them, which come out of the public health budget, I think, don't they? Yes. Yes. So that's a different but what you're doing is giving a warm space, isn't it?
Yes, absolutely.
So you're encouraging people in. It's a warm environment. You're giving them something to eat.
Is it welcoming spaces now?
Yes. So that is another grant that you can apply for.
Wonderful, thank you.
And that has just come. There's just a new opening now for that particular grant.
And they can collect from Tesco's as well.
So you need to apply for that grant because that has less criteria to or hoops to jump through is what I'll say.
Thank you. So I think thank you for addressing us. You've come with a specific question. Mm-hmm. We as a committee don't give grants.
Yep.
So our role is to make sure the council does its job. We will write to the relevant officer saying that you've spoken to us this evening.
Thank you.
And making sure that you are put into the right process.
Perfect.
To support that.
That might be an idea. So that they can hear it.
Can I leave a few of my cards with the email address on?
Yes.
Yeah.
Yes, Councillor Herring.
Can we not add in that letter that the committee, having heard the heartfelt plea, that we all support that application?
I'm sure that's right. Yes. Thank you very much. And I think what you say will relate probably to all the presentations we've got as they come along this evening. And I think, I think one of the questions this committee is really thinking about is what is prevention and how do we make sure it's happening locally in each area of our district. So thank you very much indeed.
Thank you.
Right, so are we moving on to our next presentation, which is, so we're going, the next item, so we're on to item 5, which is the Integrated Care Board, the overview of development and priorities, and Maria Laffan is going to address us about this, and we look forward to understanding all that's happening in your world. Thank you.
Thank you, Chair. I'm happy to talk you through. We've got a slide deck here, hopefully that some colleagues are going to move for me. There's quite a lot of detail in here, so I'll give you the brief sort of excerpts that come out of that. And just to start by saying, acknowledge Jean's comments through from a health perspective, and whilst we wouldn't pick up any individual cases, of course, outside of here, if Jean wants to contact us through the ICB, happy to support any further questions there. So colleagues, this is an overview of development of priorities from an ICB perspective, and I'm not going to teach you to suck eggs and tell you exactly what an integrated care board is, because I expect many of you by now will know.
I think you might. I think we are a new committee with quite new councillors. I think you might start from a position that we don't actually know anything.
That's fine.
Yeah,
Happy to do so.
Is that fair? Yeah. Just assume we're on the beginning of this journey.
Okay, that's absolutely fine. Then bear with. I'm looking at some colleagues across the room who I know are very familiar with integrated care boards. So a statutory body responsible for planning and commissioning of local NHS services. So we are the folk who buy NHS services, but also shape them, make sure they're good and fit for purpose, and make sure they're high quality. And we manage the budgets of those said services as well that we are responsible for. Equally, as the clue is in the title, the Integrated Care Board, we work really closely across our system partners to join up care where we can, to make sure that we've got that wider oversight of what's required for our population. I do apologise, I don't mean to have my back to you. What's required for our population and what's the best fit within limited resources that we have delegated down from national government. We are a statutory committee, like I say. It brings together all of our partners across health and care, and it's helpful to be here this evening to give you some explanation of what that looks like. Next slide, please. So we have a developed 5-year plan, and for some colleagues that might be new, but the detail here that we'll talk to is around the 25-26 refresh of that plan. We also have had a 10-year health plan that has been published, and some planning framework that comes out, and that comes out nationally and guides us in some of our thinking, not all of our thinking, but some of our thinking for how we commission health services, how we buy what's suitable for our populations. A recognition that as we move into 25-26, trying to work towards that plan, that the NHS and the NHS reforms are facing significant financial challenges. That won't be new news for anybody sitting around this table. So what that's meaning for us in our planning is trying to reset, look at where we can reduce waste or duplication, and we're all working collectively across that, whether it's our healthcare providers, work across adult social care, across our safeguarding responsibilities, to look to make sure that the plans that we do land on as a final set of priorities are those that are important to the people and the population of Northamptonshire, and that we work towards that, I guess, divvying out money in the right places where we can. Next slide, please. Thank you. So, from a national perspective, you will have heard, you will have read in the news, or you will have seen on the news, these are some of the big headlines that are coming out of the 10-year plan. Analogue to digital, so absolutely using digital technology in a much more productive way than we perhaps have done previously. I'd like to think all of us that sit around the table are familiar with the NHS app. I'm getting more familiar with the NHS app, and I find it tremendously useful. But there's a recognition that that's perhaps will take time for everybody to become more attuned with digital services. But with an ambition that some of that shift from analogue to digital will help us utilise our resources effectively, potential to save duplication, but also get better patient experience as well by that use. Treatment to prevention. So again, looking at our population health data, how we can start to plan healthcare in a different way, how we can work with public health colleagues around what do we do first before we have to start looking at treatment, how do we start to work towards healthier populations. A shift within that from hospital to community care. So we know across our systems currently, I am on call this evening, I should have declared that at the beginning of the meeting, so I'm really mindful of the numbers of people sitting in hospital and needing to move people out across community services, community provision, into social care, some of our care homes. So really working within that around how do we do more of that in a different way. And then neighbourhood health and services expansion. I'm not going to go into the details of what neighbourhood health means. My colleagues here are going to talk to that on the next presentation. But except to say that in principle, that's around what's right for the individual population needs and what's right for the individual needs, and having a much more person-centred approach to care. Next slide, please. Next slide. Thank you. So just to give you a sense of what our priorities are from an integrated care board perspective, Neighbourhood models that again will be described in further detail. Delivering our urgent and emergency care strategy. We know what the challenges are like in our A&E departments. We know what the challenges are like from our ambulance colleagues, and we have got clear plans around how we will respond to that and what our strategy looks like, but also to try and reduce that significant demand on our emergency care services. For children and young people, Councillor Baker will have worked closely with me on this before. We know we've got significant weight across ASD and AHD services for our children's services. We're also seeing some growth in that in adult services as well. So we've got really strong ambitions to try and prioritise that, because we know that is the most significant area of weight across some of our services. Improving access to services across urgent care, like I said, but also for elective care in our hospitals, mental health and community services. Using our data to inform what we do next. We've got an awful lot of data from our health providers that we now need to understand in a much more targeted way around how we use that information to have the proper interventions for individuals. And then trying to work back to our analogue to digital around how we use information and clinical systems in a much more patient-focused way. Next slide, please, Tracy, thank you. This is a very busy slide, and I don't intend to go into detail in it. It's essentially a plan on a page, but it talks to that utilisation of digital utilisation of the public health space as well, from treatment to prevention. Our priorities like children and young people. End of life is an example in there. We've done some tremendous work across Northamptonshire around how we link up collectively the information we have on people who are in the last 12 months of their life to greater benefit. And again, some of the other details in there around our delivery partnership priorities like maternity and neonatal services, which we know have been challenged across Northampton and Northamptonshire. Next slide, please, Tracy. New models, I'm going to skip on this one, if that's okay, Nikki, because I think you're going to talk to detail around that. Urgent and emergency care, just picking out the key areas of this. So self-care and active prevention, that's our treatment to prevention strategy. Rapid access to primary and community care, and we have heard from Jean around her access to primary care. But what we know from our data is we've got significantly more touch points for primary care and improved access as well. The numbers are in here somewhere, and I'll talk to those in a minute. Coordinated care around urgent care and a crisis response, and I think that's not just for emergency care, that's for crisis response in mental health services as well. The opportunity to be seen elsewhere and not have to be a patient at our hospital acute services, that there are alternatives to that provision. And that real priority around recovering and independence. So for some of our older populations, moving through those acute services quicker than we currently do, and being able to get people back on their feet again and not deconditioned as a consequence of perhaps some of the acute accesses. Next slide, Tracy, thank you. So again, our priorities around children and young people. Colleagues may have been aware of the development of a lead provider model for community-based services. We've got the model developed. We haven't got the service necessarily developed, and that'll be part of our procurement over the coming year. A relaunch of our system-wide children and young people's transformation programme. So that is not to say that we don't have a programme and haven't had a programme in place. We have had to relaunch that. I've personally taken over chairperson role of that transformation programme, and I think we've been able to realign ourselves around some of those priorities really quite robustly, looking at our data, looking at where our problem areas are at, and we're pushing ahead with that for 25-26. Again, working in partnership for outcomes and experience of children and young people with SEND. I hold that as a responsibility from an executive position in the ICB. It really is a challenging space. We know that. We understand our priorities for West North End's SEND programme, and we know we will be re-inspected again and will be challenged against the improvements we've made. And again, in line with the Healthy Child programme, and working again with colleagues across public health, that 2.5-year review in line with the Healthy Child programme part of our priorities for children and young people. Next slide, Tracy, please. So access to services, we've touched on briefly, but access to primary care, we are seeing improved trajectories around our primary care access. Dental access, not so much. And we have a phenomenal amount of work to do around dental access, and we hope to be able to hold on to some of the funding that comes down for dental improvement in dental care, but that's been challenging this year because of the NHS reforms and because of the wider challenges of the financial envelope. Delivery of our elective recovery plan, we know our waits in some services are longer than we would like them to be. We work really closely in partnership, particularly with our acute colleagues, around length of waits for our services. We actually do really well across cancer services in Northampton. Our performance is good, but other areas are areas that we have to prioritise around further development. And some of our transformation around mental health, learning disability and autism, again, are areas that we need that constant focus on, but likewise are limited within the areas that we have the financial ability to be able to prioritise. Thanks, Tracy. Next slide. So where are we at with all of that plan and what are our next steps? So again, aligning our work to our place and neighbours. Again, that neighbourhood plan will talk more closely to that. Strategic coordination of delivery planning. So that integration of interdependencies across different work streams, you know, we will all be talking the same language when we talk to priorities for services, for health services across Northamptonshire. We will come back here and we'll update you on our progress around what our plan said and how we've been able to progress with that. And again, touching on the points that come through our place and neighbourhood health will feature heavily in our 5 and our 10-year plan. This is not, these are not strategies that we will see in development in the next year. This is a longer-term view of some significant work we need to do with the limited resources that we have. Thank you, Tracy. So our digital strategy, again, colleagues won't be able to read the detail on there, so I do apologise, and these slides will be shared, but it just gives you a pictorial sort of guide on where we're at on that journey of digital workforce leadership empowerment. I won't talk to the detail on here partly because I can't see that either without my glasses moving up and down. Thank you. Thanks, Tracy. I'm going to skip on this slide if this is more Nikki and David's slide to speak to. Thank you. Again, and I think I've touched on some of the detail in here around urgent and emergency care. We'll share these slides, but that will give colleagues a bit of a detail of what sits behind some of our, for example, respiratory hubs in winter, immunisation and vaccination as well, working harder across some of our priorities in emergency and acute care, a winter plan, for example, of what this winter will look like and some of the additional planning that has been put in place. And again, discharge and recovery support. We work really closely with our colleagues across adult social care about how we work to support people and communities and individuals who find themselves in acute care moving back out, hopefully into their home or into supported areas. Next slide, Tracy, thank you. Again, I won't go into too much detail if that's okay. I'm mindful this is the adult oversight, so I won't go into too much detail here, but that just again gives you some of the priority areas that we work to across children and young people. And again, SEND featuring heavily in that place. Thank you, Tracy. Next slide. That's probably me and some of the details I'd like to share with you. Happy to take questions from colleagues.
Yes, I'm sure we've got questions, yes.
Can I ask a question?
No, Jean, I think this is the point. No, Jean, this is the point at which the committee has the opportunity to ask questions. Yeah, maybe hang on to it, and maybe afterwards you can. Adrian, yes.
Thank you, Chair. I may be mind reading here. This discharge and recovery, just like an exit interview from hospital. So we are making sure that people leaving hospital aren't going to an empty house. There is someone to support them, especially if there are mental health needs.
I can't talk to the detail of exactly what it looks like, but absolutely in spirit of people are safe when they are returning home. If they are returning home, what does that look like? That's in place currently. We wouldn't see anybody discharged home alone. If there are examples of that, I'm happy to hear that, but that they would be long-term provision in any case, that is clearly articulated for many years. So if it's not like that and there are examples of that, I'm happy to hear them.
Thanks for that. I think Jean might have some points on that later.
I gather that the ICB is going to be taking over the role of Health Watch. You haven't actually mentioned what that will look like. Does it have any impact on this committee, actually? Because it feels slightly like marking your own homework.
Yeah, thank you, Councillor Herring. I think that's a fair comment. Some of that narrative came out very early days around part of the NHS reforms, but part of the what next and some of that commentary from government. There hasn't been any further detail that I'm aware of from an ICB that says, and this is what this looks like. So I take the point around marking our own homework, but I guess I'd refer back to the comment that Councillor Purser made at the opening of the meeting of the opportunity to co-produce, the opportunity to understand what good looks like. Certainly from my perspective and my ICB portfolio, it absolutely is around patient experience, patient engagement, quality of services, and we work very, very closely with Health Watch. Currently have Health Watch sitting around our integrated care board as well. So we're very familiar with the work that Health Watch does, but we're not the independence of Health Watch. So I take your point. I don't have the details. I don't know if other ICB colleagues have. We haven't been made aware yet of what that looks like. We will work with that as it comes.
It seems to me that when you talk about co-production, there might be a role actually for this committee to work in partnership overseeing some of the complaints procedures. Thanks.
Happy to have those conversations.
Thank you, Chair. Maria, you clearly have got, you said, significant work with limited resources. Boy, have you got significant work with limited resources. And you mentioned dental access maybe not going quite as well as some other areas. My question is broad, to find out what causes you most concern within the plan as a whole, given the significant work and the limited resources?
Thank you, Councillor Ware. I think I'd refer perhaps to our priority areas. I think all of those causes the most significant concern. And I recognise we're here in an adult space, but for me, it's the children's space that is our most challenged currently. We have significant weights in that area. But actually also some of the dental access, I sign off all of our complaints from an ICB perspective, and there's a significant amount of them around dental access. Now that's partly because we have had some failures in provision in the business side of provision, and we've had to rework that through with support from regional colleagues. And I recognise how let down people and families are when something like that happens. But we have had a long period of waits for dental access nationally, so it's not a distinct feature to Northamptonshire. Our challenge is around how we can assure and provide additional resource into dental access for people so that we don't have children and adults waiting a significant length of time. But I think to answer your question, certainly children's priority is something that is at the front of our collective priorities for health. Thank you.
Can I ask a question really about the planning of services? Because as an authority, West Northampton, we've had significant population growth that is likely to go on into the future. Certainly when we look at from a planning policy point of view, I'm not sure that we sense the health input in terms of what are the issues that an expanding population will have on demands for both primary and secondary care. And I kind of was looking at some figures. If I'm right, we've got 790 beds for 450,000 people, whereas the Walsgrave Hospital has 1,005 beds for about 300 and 60,000 people. We would see, that's just a back of the envelope thing. I'm concerned that we have a 1783 hospital requiring to meet 2020 needs, and really I want to know that by say 2050 what would hospital care look like, and how do we move in that direction? Because I think over the last 20 years, as the range of authorities, we've made no progress in dealing with that.
I'll do my best on that one, and I haven't got a crystal ball to tell you what 2050 will look like. But what we do know is that we've got very detailed business intelligence around our population. I might include my colleague from a population public health perspective. But I think we have got very advanced information that will start to tell us what that might look like in the future. But also those priorities that you have seen on screen, those priorities are really there to reflect that growth, to reflect the complexity of the type of presentation we will see as well. And I'm not an expert in this area, and we can bring that back around, I'm sure, in another meeting. But suffice to say, those headlines that you see around priorities in planning that are that national objective of shift from acute care to community, treatment to prevention, all of those recognise that absolute expansion of population growth, the age profile within that, the likelihood of an older age profile with more complex demands. All of that feeds into our planning of how do we do this differently and what the important points are around that. I don't know, Chloe, if you wanted to add.
Hi, yeah, I just wanted to add. So I think we got the NHS planning guidance came out last week or the week before, which sets out requirements for more detailed plans, and we've started to have conversations with the directors of public health and their teams working with population health to look at. We're required to do detailed planning and forward planning, looking at our predicted health needs, and then we've got to produce a place plan which will set out how we're going to move to a neighbourhood model, which is required by the end of the year, which needs to be led by local authority. It sits under the Health and Wellbeing Board, led by the Health and Wellbeing Board in partnership across local authority, NHS and partners, and then the ICS has to pull together all of those place-based plans to create an ICS plan, and then also the providers have to develop their own kind of operational plan. So again, that will be on a place footprint for the NHS provision. So the new 10-year strategy is setting out more detailed requirements and expectations around this work, and we're starting to have those joined-up conversations about how we work together with our ICB population health colleagues on that. And it will come through the Health and Wellbeing Board. We've got an agenda item at the Health and Wellbeing Board on that as well.
But I'm keen that it feeds its way. As a local authority, we've got a development plan that we're working on at the moment that will come to a conclusion next year. I think it's very important that the health components are really built into that, including and we've heard nothing so far about what hospital care might look like during the planned period, which is 20, 30 years. And, my experience is that for us to develop, we've got an 1783 hospital, really. It seems it's going to take a long while to get a plan into place and all the components that is going to be fit for purpose for 2050. That's my question, really. Sorry.
Thank you, Chair. We've just at the moment going through a process with an organisation that NHS England have provided with us, given to us to give for support. We're actually modelling what we think the next 15 years look like at the moment in terms of activity, particularly around mental health, acute and primary care. Now, when we do that modelling, we take into account everything that Maria was suggesting earlier around population growth, around demographic changes. But what it all enables us to do is start to look at scenario management. So it says if we continue to deliver health in the way we do today, in 15 years' time, we know how many beds we will need.
in the county and how many more GP appointments we'll need in the county. But the work that we're trying to lay over the top of that is to say, well, we're not going to be doing things the same way we do now in 15 years' time. And we can start applying our 5-year plan or our planning and our thoughts that we've got at the moment in terms of interventions, some of which we will talk about today, in order to be able to assess what we think the impact of those will be on that growth. So then we get into a point when you start to lay the impacts on and you start to say, well, if it delivers at a high level, what would it mean? If it delivered at a lower level, because some of these interventions that we'll put in, some will be really effective, some will be less effective. So you have to start scenario planning around those issues. What that will end up being longer term, so this is the first phase of a planning process. What we will end up doing longer term then is taking that modelling and then starting to think about what that means in terms of a state. Yeah. And that will drive a state strategy for the next 15 years in the county. So the first phase of that around the clinical modelling, as in how many beds do you think we're going to need in 15 years if we do nothing, that is due to go to the Integrated Care Board, I believe, possibly next month. So as draft. So that will start to be widely circulated. Lots of people from around the system have been involved in the development of that as well.
Hi, I know we've talked about the NHS 10-year plan, and really my question was more to do with waiting lists and in particular with mental health issues affecting right from youngsters, 18-year-olds, all the way up to elderly and everybody in between. It was to do with what are we actively doing whilst people are waiting, really? Are there any active interventions while people are waiting to help them in terms of prevention?
Thank you. There's a whole host of different options for people whilst they're waiting, and that starts from a younger person's perspective as well. And of course, as you would expect, there's different needs drive different responses, so they vary in what they look like. Certainly from a young person's perspective, we work really closely with parents and families around what might that look like. We'll work closely with our partner colleagues in education from a local authority perspective, as well as how we weave some of that in through schools and other areas. But from an adult perspective, from a delivery of community mental health services, for example, from active oversight of people waiting, people in initial appointments and second appointments, there's an active oversight of that from our mental health organisation, our community mental health organisation as well. I wouldn't want to go into the details of it because I won't know them off the top of my head. David, I don't know if you want to comment on some of them. Thank you.
So just to give a flavour, and it will depend on the type of service and the type of need, but some of the things that happen. My name's David Williams. I work as Group Director of Strategy and Partnerships for Northamptonshire Healthcare Foundation Trust, which is both a community and mental health trust. Some of the services we do, we have things called iDiscover, which is a recovery college, an online package of resources and materials that's available for young people. Recovery College is something that's there as online resources that's available for adults. Mental Health Hub, an ability to call 24/7 for urgent advice and support if people feel they need it. There are a network of neighbourhood cafes run by the voluntary and community sector where people can go and ask for advice and seek that in local areas. There are also things that staff will call and check in with people. So there is a range of different support there, and waiting times do vary depending on service need and range of working things through.
Thank you, Chair. I was wondering if we had any sort of data on smoking-related illnesses, how much of the hospital capacity is taken up with the various problems from smoking, and if we know if it's getting better, worse.
I can give you the prevalence of smoking, but I don't have the hospital data to hand, but that is data we can access. So I think our current smoking prevalence for West Northamptonshire is about 12%, and we saw it dropped down to 11, then we saw a small increase in the last year, but the data does lag. But we know that's variable, so some populations have much higher smoking rates, and that's aligned with the inequalities issue. So routine and manual workers, I think we have very high smoking rates for our routine and manual worker population. as well as our Eastern European community. And that is one of the biggest drivers of demand for services, particularly the respiratory conditions, but also links to cancer. I don't have that data off the top of my head, though.
How are you getting these figures? Are you from people going sick to the doctors and hospitals, or tobacco sales, or
the prevalence?
Yeah.
The prevalence data.
Yeah.
There's a population health survey, so it's published at the Office of Health Improvement and Disparities publish data on, and there's a dashboard on a whole host of public health indicators, and that's one of them.
Thank you.
Can I talk about GP services? And again, this is what's in the local paper, which is satisfaction rates with surgeries. And with our inequalities in health, and that the surgeries that seem to have the highest satisfaction rates are in areas where you've got the best health outcomes, and the surgeries with the poorest satisfaction rates are with have the highest health problems. Is this an issue you deal with, and how are you tackling that?
Thank you. Yeah, so it's an issue that we deal with from a patient experience perspective, and you're quite right to point out the primary care element of that and that dissatisfaction element. We do understand it, and we work closely with our primary care around what's driving that, what does that look like. Sometimes that is around, as you describe, the area in which primary care is the location, for example, in where that practice may be sitting, and therefore the population that they are trying to meet the needs of, or those population trying to access primary care in the way they need to. I think the development, and again, I don't want to speak to the next presentation, but the development of neighbourhood models that will start to meet the individual need of patients is a different perspective on how we improve satisfaction, how we improve access to healthcare in a different way, because not all of those areas will be currently able to meet that level of expectation that is driven in primary care as well. But where we can, we respond to patient experience of, if it's poor quality of service, for example, we absolutely will be responding to that. We'll work closely with primary care around their regulation, for example, with CQC. So we'll understand if it's poor delivery of care, or indeed if it's around inequality of service access.
Councillor Herring.
I was just going to ask, and it was on the capacity issue, whether you monitor corridor care in A&E and whether it's increasing. It seems in general it's become almost accepted, and whether you count that in as the need for proper space, and whether there's a need to actually reconfigure the whole of the emergency intake.
Yeah, we absolutely do monitor corridor care, and we know our local acute hospital has had some significant challenges over some of the delivery of care in their ED department. We do work closely with CQC as a regulator of those services, but we also work closely with the trust themselves around what does that look like when they have to care for people in a corridor. So there's absolute standards of care that are adhered to. That's the bit that we monitor around if you're needing to nurse somebody or care for somebody in the corridor, which is less than where we would want to see care being delivered. What does that look like? Is dignity maintained? All of those areas that we would want to see held as a principle of quality. We are seeing less people managed in corridors, but we are restricted by the estates. I think you described the acute trust as, I can't remember when it was first built, but it's definitely a very old building, and the estates that I've walked around doesn't lend itself to being easily able to care for people in the same way as a new shiny hospital would. But we do monitor that. We absolutely have detail of that, and we work closely with the trust around what that looks like.
And the time limit that at which people are left, is it 24 hours, 48 hours?
Yeah.
We've all heard historic information of 3 days before people can actually get admitted to award, but I just hope that it's actually taken into account with your review of the capacity, particularly because it seems to be that that's one of the main pinch points that needs addressing.
So we collect that information, and myself and my team, so we collect the numbers of what that looks like, but we collect the detail of what that looks like, what happened to that individual and why were they waiting that long. And we work with the acute trust around what happened there, what was the... there's often many other influencing factors, aren't there, like ambulance waits or primary care waits, but we look at that, we work through it with the provider, and we look to see if there's any learning or if things could be done differently. It's a pressurised area, you know, there's not a quick response to it, but we do monitor it.
I think we're beginning to have used our slot for this item. I suppose the question I want to ask the committee really is, are there any particular issues that we want to kind of note and take forward and perhaps refer to one of the cabinet members? I'm quite keen that we make sure that the cabinet member for planning takes into account the future of the changes within the health service that are happening, so that we're right up to speed on that, because I think we've been behind the game up till now, and I think we need to get ahead of the game for the future. So I think that's one of the issues I'd want to, as a local authority, we'd want to really make sure that we've got procedure and mechanisms in place to really liaise very effectively with you. Councillor Baker.
I was going to say a similar thing, but I think also with our large developments, which I've just come from discussing, we've got, where I live, we've got 3 coming up with probably another 3,000 houses in Brackley, which haven't started to be built yet on top of what we've got already. But we know that we are open with these big developers to ask them for things. And we've never really asked for the healthcare aspect of it in our 106 contributions. And I know that the NHS and IC will not have funding to build these places, but maybe if we could get developers to pay towards the building, that you could staff them. I don't know, but it's an area I think we need to look at.
Thank you, Chair. That is something that's on the plan already that we're working on. As the chair of the Strategic Planning Committee, I talked to the planning team on this. It won't be ready until the end of next year, but extra healthcare capacity from developers is on the list already. Happy for it to be included on here anyway, just as an extra, but it is on the list already.
Sorry, but it's something that has really irritated us all as councillors going forward, because all we can ask for of developers is stuff, is a building or land. And actually, because of the changing type of healthcare, where we're trying to put more into the community, what we need to be pushing the department for is a per head, a per capita contribution for health, because of the total change in how we're actually delivering health. So keep on bashing as much as you can, because that's the only thing that's actually going to mean that they make a proper contribution to the need of the population.
Thank you, Chair. Yeah, things like GP surgeries, they're private businesses, so I don't see why that can't be looked at when the planning comes up to get a local doctor or sort of put a bid in to have that. You know, so they pay for it anyway. They buy it.
We are going to be looking at inequalities when we've talked about Chloe's thing, but I think there is an issue there about the role of primary care in health inequalities, actually, and I think that would be one of our streams, so I think we'd want to hang on to that. So we've got two things that we're taking out of your presentation at the moment. I'm sure there should be other things. I mean, obviously we talk to our adult health colleagues. I'm really, and maybe it will come out of the models of care discussion. Right, I'm going to say we've talked enough. I'm going to put the guillotine on this item now. Any final points that before we just thank? Do you know? Moira, no. Moira, any final comments you would want to come back to us on?
No, I just wanted to say thank you for having me here this evening. I can't stay for the full meeting. I do apologise, I am on call, but thank you. And any questions I'm happy to take outside the meeting.
Thank you very much, Maria. And yes, so shall we move on to our second presentation and welcome... there we are, David Williams and Nikki Adams, and we look forward to your presentation, which I think very neatly follows on from what we've just heard. So fire away.
Thank you very much, Chair. So Nikki and I will share this presentation. We'll take you through some slides. I'll do the first few, and the first few will focus on neighbourhoods. And then Nikki's going to talk through a specific thing that we talk about called new models of care. And that's very much about how do we make a difference in a neighbourhood and how do we transform and change some care and ways of working. So there's a few slides. I think I'm going to do the first 8. That was 1, that's number 2, and that's number 3. So all I wanted to do was just to add and just build on the stuff from Maria about the 10-year plan and the ways of working things through. So there is a real focus that says, what can we do to transfer care from hospitals to communities and find a different and a better way of working from neighbourhood focused care. That's important because people get better outcomes if they spend more time at home. So this is focused about how do you then have a community that can wrap around somebody, how can you support somebody if you do spend a long period in hospital, and many older people will be in hospital for periods of time. Actually, what we would call the decompensation, the challenges of continuing to walk, mobilise. If you don't have to go and make yourself a cup of tea, you're not walking around your house, those things have a really big impact. So if we can help people and build a greater resilient community, that does link into some of the things that Joe raised in the question earlier about how do communities support each other and take it forward. From a national and local perspective, we see that as being a good thing. So that's the focus. We're going to talk about neighbourhoods. The NHS is always special. So it has a slightly different version of neighbourhood than the one that you'd probably use in your minds when you're talking about neighbourhood. So in neighbourhoods, we're really talking about different spaces in the county, in the West Northamptonshire Council area. We're not talking about a neighbourhood being a part of town or a little bit of this or a little bit of that. So our neighbourhoods are larger, and you can see the list of the neighbourhoods that are on there. So we've got 5 neighbourhoods that cover West Northamptonshire, and it's at that sort of scale that you can run a number of services. So you can run some stuff a lot closer, so you can run various different bits, but there are times when you need people to be able to move a bit of distance from home in order to get specialist services and understanding of ways of working. So there are 5 neighbourhoods, and they are agreed with ourselves as from an NHS perspective, but also with West Northamptonshire Council, and we're all sitting down at the moment about how do we make our teams integrate and work together. So taking the very bottom, we've got rural east and south, but how will we make sure that the social care team are really interfacing with our community nurse team, with our mental health teams, and finding ways of working things through. So that's the sort of scale we talk about on neighbourhoods. It's really important. Government launches a big new plan and it says we're going to do neighbourhood care. What we'd like to say at this point is we have already been doing neighbourhood care. This is the opportunity to expand, take it forward, think about different ways of working and build on it. It's an evolution, not a revolution to ways of working. And just taking Councillor Cartwright's comment earlier, ageing well on the top left is a service that is there to support people as they're coming out of hospital. If we identify certain categories of people who we think are alone or struggling, actually Age UK or GP practice could be one of our services, it could be a social worker, would go round and see them. We know they've come out of hospital. We want to make sure that following that they are okay in mobilising, continuing, but especially if they live on their own as a way of working things through. So there are other bits we do, social prescribing, which is about using community resources, ways of working things through. A really important bit about how do we work with voluntary and community organisations and build that community resilience, because you've had a lovely example from Joe today, but a hot meal and some company often avoids a lot of people feeling lonely, coming down a mental health route, a anxiety route, a loneliness route, or depression. That's changing the way that people are living and working things through. So there's really important bits about that. Family hubs is something we've been working with children and young people services, thinking about actually how can we create close to one-stop shops where people can go and get support. I don't think it will ever be a perfect one-stop shop, and the best example I can use from that is if you think about the estate that's in, say, Daventry at the moment, we've got a GP practice and the council offices at one end of the town centre, we've got Daintree Hospital and another GP practice at the other end of the town centre. Actually, we just need to make best use of those buildings. It's highly unlikely that we're going to get the money to knock all 4 of those down and rebuild a single neighbourhood healthcare centre. So there's a bit of pragmatism about it. But if we can have family hubs, one-stop shops, there's some good stuff happening in Toaster, ways of working, all of that I think's there. And the other bit I'd just say on here is, so my organisation, NHFT, already provides care around 100 locations across the county of Northamptonshire. If you add in other providers and ways of working, there is care already happening in about 170 locations around the county. We have a habit of focusing on the Northampton General Hospital, maybe on Berrywood, maybe on Daintree, but there is an awful lot of care that happens in different settings and different ways of working. So we already provide it, but what we recognise is this is the big shift to doing something different. This is the way to find something else and to find a way of working. So as an example, we've got a few things here about how do we need to make the services work differently? How do we need to sit there in neighbourhoods and do some stuff? And we've taken a couple of examples of some figures that Nikki will talk a little bit about. How do we know about the needs of different people in different neighbourhoods and ways of working? But we do have a lot of data between the NHS, local authorities. We know a lot about the needs of patients. So I've put some examples in there. So we know, for example, when we ran this data, there were 913 women who were pregnant in Wellingborough, and they would be classified as being low complexity pregnancies. So you can tailor a package with organisations working together for those 913 people. We know 670 people are the most frail living in Corby. So again, you can have a conversation in Corby as a neighbourhood to say, how do we work it through? And we know we've got 134 complex pregnant women in Daventry and Toaster. And again, if you think we're bringing loads of providers and different people together, actually, what do we need to do for those 134 starts to become a very specific question that providers of healthcare and social care and voluntary community organisations in and around Daventry and Toaster can have. And that last example we've got there is 1,182 people in central Northampton with a mental health need. So we think by breaking some of this stuff down in and saying, right, what can we all do in Daventry and Toaster? What could we do in central Northampton? Actually, we're bringing together organisations of ways of working to say, how do we do it differently? So that's the integrated response. That's what we want to do more of in neighbourhoods. We're doing some now. It's not perfect. There's some good examples. Councillor Cartwright's examples of who gets support coming out of hospital. Not everybody does from the list you ran through, but we do some. So what we want to do is reduce length of stay. If people stay in hospital for less time, actually there are better benefits from them. We want greater expert patients, really helping to support people understand how to take responsibility for their healthcare and how to own that and taking things forward. Lower readmissions is really important. You don't want somebody to only stay in hospital for a couple of days, they go home and then they come back in again, because that would cost more money and is a real big issue for the individual. But the other thing is coming back to how do we combat loneliness? How do we create communities? For some of us who are a little bit older, it's going back to some of the stuff that would have happened years ago when we would have encouraged people to knock on the doors of others, support stuff, thinking those things through. But that's the important concept around neighbourhoods. I've just got one other bit, I'm just picking it up on the next slide, and I've touched through on those. But, if we get stuff right, we could improve volunteering. We want to look at immunisations and vaccinations and really build that up. That's an important part of wellbeing, tackling inequalities, and thinking about community messages around there. You'll see the other things are going around there, but lots of different elements that we want to bring together as we go through neighbourhoods. So my last slide is the next one. So we need to think, how do we do and embrace neighbourhood care? So remember, the neighbourhood care for us is that slightly bigger area of West Northamptonshire, that kind of 5 different bits, but we really need to sit down with everybody and think about how do we make it work together. Enabling local leaders and local voluntary and community organisations to say, this is what we need in Daventry, it's slightly different to Towcester, which is different to the centre of Northampton, are all important kind of conversations to have. I would say that health and care providers over the last 10 or so years are now shifting our cultural approach, which was very much a bit of a, we've got a boundary, adult social care would do this, NHS would do that, a voluntary group would do something different. And I think we've really shifted over the last few years to working together. And there's some lovely examples, and another time I talked to you about working with Chloe and also children's colleagues in the local authority. But we've got to change that culture that says actually what we're all going to do is work together. The work that you support in West Northampton Council makes a huge difference on people's health and well-being. It won't just be our work. The work that happens in schools makes a huge, great difference. So we want to change that culture and bring everybody together, create the space, champion that local working, and really build something that is kind of what it should be rather than what it has been. So that's hopefully a quick run through of where neighbourhoods are. The next bit as it goes on is Nikki's specific bit about intervention we want to do that we call new care models. Is it all right to do that?
Yeah, thank you, David.
I've just realised I'm afraid about them banners and stuff.
Thank you very much.
Luna's got my cards. Thank you. I'm just leaving it. Services we provide, even everything we're talking about.
Ruth, yes.
Just a comment before you carry on with the new models of care. West Northampton doesn't finish at Towcester.
No,
and so I represent a whole group of people who actually look into Oxfordshire for their healthcare, but often the communication between the two in terms of transitioning from hospital care back into the community is not great. So I just log that because you kept mentioning Towcester.
And I wasn't ignoring Brackley, but equally if we have a competition, there's probably another few wards and other things that I haven't mentioned today, but that wasn't deliberate. And absolutely, yeah, we've got services in Brackley, and that particularly that dialogue between Brackley and the Horton in Banbury and making sure those things work, it always remains important.
Okay, I think can we move on and his presentation, and then we'll have questions. Otherwise, we'll be too midnight. I'm keen that we crack on.
Thank you, Chair.
Yeah.
I'm going to I could talk about what I'm going to talk about for a few hours. I'm going to give you really just an insight into this, and I'm sure there'll be much more dialogue that we need to have in the future. So do you want to go next slide? So I'm going to talk to you about new models of care. So this is an initiative that affects GP practices specifically, but not exclusively, around trying to make access better and freeing up time of GPs to work more in a neighbourhood environment. So over the last 2 years, we have been working on a programme called New Models of Care. And I think it's really important to recognise that GPs all work to a national contract, and I don't know how much you know about GPs, but their terms and conditions and the way they work and the service offer that they offer to patients is all negotiated nationally. We as local commissioners have the opportunity to build on that national contract by adding things to the contract, by paying extra to ask GPs to go over and above and beyond that national contract. So what I'm describing to you today doesn't interfere with the national contract. This is about us adding more to that to get a better service offer for our patients. So around 2 years ago, and I'm sure many of you have follow the national press, access to general practice is always a challenging area, isn't it? It's the area that often comes up in scrutiny committee discussions. It's an area that we get quite a few complaints about. So in Northamptonshire, we're trying to do something about that, and we're trying to be really proactive and do something probably different to the rest of the country at the moment. So we've been developing an innovative new programme, which in essence is around trying to provide additional GP appointments. I can say GP, but it's not entirely GP. It's GP and what we call advanced practitioners. And those advanced practitioners can be nurses, specialist nurses, paramedics, to provide additional funding, to provide additional appointments in a neighbourhood setting for patients. And by providing additional funding to that neighbourhood for those additional appointments, what we're trying to do is then protect some of the time of the GP practice, and want to protect some of the time of the GP practice because we need our GPs to have much more protected time to spend with patients with complex health needs. And as we know at the moment, and the 8 a.m. rush is probably getting a little bit better than it used to be, there's always been this deluge of calls, isn't there, 8 o'clock in the morning when everybody rings their GP practice and tries to get in, and the older frail patient is up against the techno patients that know that how to do all the auto dialing to try and get through an appointment. So it can be really challenging, and sometimes what that means is that patients that have got the greatest needs aren't always the patients that are getting the appointments. So this model is about adding capacity to a neighbourhood for patients, and therefore freeing up time of GP practices to be able to focus on complex care long-term condition management. Those additional appointments that we want to buy will be delivered as part of what we call a neighbourhood access service. And I'll go into a little bit more detail about what that neighbourhood access service means when we're going through this. Now, because we're kind of in this position of innovation, we are going to move forward the new models of care programme, and the business case has just been signed off by the ICB board to trial this new way of working in 2 neighbourhoods across the county, one of which will be aligned to West Northampton Council geographical area, one will be aligned to North Northamptonshire geographical area. And those 2 pilots will be offered initially a guaranteed contract for 2 years. But what we've absolutely got to do with these 2 pilot sites is prove that actually by adding additional capacity into over and above the nationally negotiated contract, we can actually start to change the way care is delivered for patients and improve outcomes for our patients. So if you just move through to the next slide. So when we start to think about designing services and what patients may be suitable to go to a neighbourhood access service, we recognise that if you are an older frail patient or a patient with complex health needs, if you ring your GP practice, you actually need to be with as close as possible to your named GP. You don't want to be going off to a neighbourhood health centre because continuity is absolutely the right thing to do. So, what we've got available to us in Northamptonshire now, which has been growing and developing over the last few years, I don't know whether you've heard of it, we've got the Northamptonshire Analytical Reporting Platform. I don't know if anybody's heard of that. So that is a digital, it's like a digital warehouse that pulls data from all different organisations, including social care data at some point in the future as well. So, and it really starts to enable us to have a level of insight into population health needs that we've never had before in this county. And what we, as part of supporting this programme, what we're doing at the moment is working with our local authority colleagues to start to develop neighbourhood packs. And those neighbourhood packs will have a more detailed understanding of what that demographic is in that population, what the health needs of that population are. That pack will develop as we kind of enhance the programme as we go forwards. But what we are able to do, as you can see on here, is start to risk stratify the population. So in any one of our neighbourhoods, we will be able to identify patients we'll be able to risk stratify them from our lowest need patients right through to our frail patients, and we'll be able to describe exactly how many patients sit within each of those cohorts. So when we start to think about developing services around the new model, so the neighbourhood access service part, we can start to identify which patients would be okay from a clinical safety point of view, would be okay to go to a neighbourhood access service rather than absolutely need to be with their named GP, because they've got a level of complexity that if you went to a neighbourhood access service and was seen by a random GP, you probably would end up with your regular GP if you did that. So, and some walk-in centres across nationally have kind of not been successful nationally, where you get complex patients turning up at walk-in centres and then end up straight back at their GP practice. So part of this model design, we've got to make sure that doesn't happen. So, and this population stratification enables us to start identifying which patients we think are suitable for whichever service. So just going forward to the next slide. So the neighbourhood access service and says key features to it. So from a patient perspective, if you are in a neighbourhood that's participating in as an innovator site, your access to services does not change. So you continue to ring up your GP practice in the way that you always have called up your GP practice. The GP practice will have a discussion with you, and if you are low complexity, may offer you an appointment in a neighbourhood access service. Now, and if you've got higher complexity, then the idea is you try and get you in to see your regular GP, but perhaps not for 10 or 15-minute appointment. What we're trying to say is those patients actually, in some instances, will need a 30-minute appointment, because actually the GP needs the time to be able to work with that patient and get a proper care plan in place to stop the escalation into hospital. Now, when we think about the neighbourhood access service, we don't know what that looks like in any one neighbourhood. And very early on in the development of the programme, we started to think about, well, is this a hub, is this a physical building in the neighbourhood where patients are directed to go to see a GP or a nurse or a paramedic? And we still don't know the answer to that, because part of this is identifying two neighbourhood innovators and empowering them to work with their communities to co-produce what the model looks like. Now, for some, and it depends on the neighbourhood, because if it was a neighbourhood in Northampton town, it's quite feasible actually for the geographical nature of the town that you could have more of a hub type development of a neighbourhood access service. If you go out towards Daventry or Brackley area, it might not work so well in that area because it's much more geographically dispersed. So therefore, a model might mean that the neighbourhood access services works out several GP practices, but you might be asked to go to different ones depending on the need. Just to get a feel for what we're buying, for an average 93,000 neighbourhood, we're going to be injecting around 1,400 additional appointments per week into that neighbourhood, which is a significant growth in appointments into that neighbourhood. So the ICB is physically putting cash in to buy those extra 1,400 appointments. In return, the GP practices can stream some of their patients into that service, and the freed up time that they have, because they're no longer seeing those low complexity patients, that is the time that they would need to spend on delivering more enhanced offer for complex care long-term condition management. Next slide, thank you. Which goes on to this slide. So when we talk about enhanced complex care long-term condition management, this is very bespoke to the patient. So and it's very much around the GP practices starting to design what that looks like. And again, we've said to the neighbourhoods, we're not going to define that. We're not going to define that for that neighbourhood. We need the neighbourhoods to use their neighbourhood packs and look at areas of priority in that neighbourhood. So one particular neighbourhood may decide in one particular year to say, you know what, we really want to focus on diabetic care, we want to get it right, and we're going to have a real focus on it, and then we might move on to heart failure. So we're given the freedom, because that's what neighbourhood care is about. It's about empowering people in the neighbourhoods to work. Freeing up the GP time, and as I said, this is kind of GP-centric, but not exclusively. The idea is to free the GP time up so they've got the time to care and the time to engage with wider community assets in that neighbourhood. Because at the moment, if you think about a GP day, and if you get the opportunity to talk about a GP, they'll talk about the number of patients they see, which generally is anywhere between 15, 18 appointments in the morning, 15, 18 in the afternoon. then all different healthcare professionals calling them all the paperwork. It's a tough old job to do, and having the time then to then reach out into your community and start trying to put packages of care around patients, they're not getting the time. So with freeing up this time and taking that low complexity work away, we're hoping that the GPs will be much more able to integrate and facilitate much better joined up working within a neighbourhood. Next slide, please. So where we are at the moment then, we've nearly finished the governance in the ICB. It's been a long old journey, but we've nearly signed everything off for that. We've got one more hurdle to go over. We will, I think at the moment we're on target to do this. On the 17th of September, we're writing out to all of our GP practices to ask them to come together in their neighbourhoods to express an interest in becoming an innovator site. For a group of practices, I'll just pick a random neighbourhood. So Northampton Central, for example, as David put up on the neighbourhood geography earlier. If Northampton Central wanted to submit a application for an innovator site, it would need to make sure the GP practices that are in the boundaries of that Northampton Central, that 75% of the population was covered, so that you need to have enough GP practices that were interested to be able to participate. Because remember, this is not about us changing the GP's national contract. This is about adding something different. It's voluntary. So there'll be some GP practice in this county that says, I don't want to get involved in this. So part of that expression really is now for the GP practices in that area to think about where they want to participate, whether they can come together to work together, and whether they want to express an interest in becoming an innovator site. We anticipate that we will by we're roughly on target for middle of October to end of November that we will confirm the 2 innovator sites, and then we'll go into a 5-month co-production. And we're working with people like Mark Major for Northamptonshire Carers, and they've got voluntary sector representation in our groups, and they're working with us to try and work up a framework for those neighbourhoods to use in the co-production of that service. And how we develop that. And just at the bottom is just a bit of information. So the appointments will be 15-minute in length in the neighbourhood access service, longer potentially if you're complex and you're staying in your GP practice for that appointment. There'll be a mixture of virtual face-to-face, there'll be GPs and advanced practitioners, and that where it says average appointments 1,050, it's not, it's actually 1,400 per week. And we're also allowing in the model for neighbourhoods to start thinking about whether they bring specialists into that model. So the neighbourhood access service is about low complexity patients, but we're allowing innovation in that neighbourhood access service. So that means that the neighbour could start to think about whether they bring a GP with specialist interest or potentially even engage a consultant to work in the neighbourhood model. So that means you wouldn't need to ordinarily be referred. So if you've got a dermatology issue, you may find that you'd be able to see a GP with specialist interest with dermatology in the neighbourhood access service, or there may even be a consultant, and therefore you wouldn't need to be referred into hospital to do that. So it'd be much more rapid care. And the idea is that these sorts of patients that have historically escalated into acute care will start to be managed much more comprehensively in the community. And it's that by making that shift, and there is, and I haven't got time to go into it today, but there is a huge benefits realisation programme wrapped around these innovator sites where we have to prove that by investing the money that we're investing to buy the additional appointments, we can stop the referrals going into the acute, or the patients turning up in A&E, or the ambulances transferring patients into hospital and then struggling to get them out. So all of that we need to assess in terms of what impact have we made, and can we prove that actually by doing this we can take activity away from our acute sector and reinvest money from the acute sector into our primary and community care setting, and therefore roll this out to all 9 neighbourhoods within a reasonable time. And we're looking at about a 5-year rollout at the moment for all 9, if we can prove the 2 innovator sites are successful. That is a whistle-stop tour, but I hope I've given you a feel of what it's about.
Can I thank you both for a really fascinating and important project, which really, I mean, I'm really quite excited by what I've heard, and actually some of the other stuff that I've seen that is where we, as Northamptonshire, we're a demonstrator area for national stuff. So that's really encouraging to see that. Fiona, come in.
Sorry. The only thing that I think it's really exciting, but the only thing I'm concerned about is the triaging of these patients, because the complex cases are obviously people that the doctors know about already, because that's how they become complex. So how would you work with somebody? You know what people are like when they ring up. They tell you they've got a cough, but then you find out they've got lung cancer. So how do you triage those people to make sure that they're seeing the right person at the beginning? Because there has been issues on the news, as you probably will be aware of people that were missed by seeing a lower qualified practitioner.
Okay, so for a start, there's going to be nobody that's lower qualified in a neighbourhood access service. They'll all be they'll be as qualified as anybody in a GP practice. Now, there will always be patients that are presenting for the first time with something like a suspected cancer that have been ordinarily very healthy, and therefore quite possibly will end up in the neighbourhood access service. The moment that's picked up, and there's just equal chance of it being picked up in your GP practice and neighbourhood access service, the moment that's picked up, that changes the patient's complexity. And so what the neighbourhood will do is design a process which is very fluid. So as patients' complexity increases, they will regrade the patient in terms of that's a complex patient. Don't send that to a neighbourhood access service as those sort of things are picked up.
Councillor Herring.
I share Councillor Baker's concern. I think this is incredibly worrying. There has been a lot of criticism about using practitioners, therefore not trained doctors, and I am concerned that the patient will not understand the difference and will go to these practitioners, these neighbourhood hubs, and think that they've been seen by a doctor. And I believe that if you're changing a service, particularly this fundamental, that you have a duty to consult with the community. And what are you actually going to do about that?
Yeah. Okay. So GP practices already use advanced practitioners already. It's no different. These are existing GP practices right now. So you have paramedics, you have physios, you have nurse practitioners. So we're not changing the configuration of the workforce in that respect.
But they're seen by a doctor first. It's the doctor that decides where they go.
No.
Well, they are in our practice.
Yeah, not exclusively. In any neighbourhood access service, whether you're in a GP practice or whether you go to a neighbourhood access service, the GPs are always going to be there. So if you get in many practices, you'll go straight into a nurse practitioner appointment. And if you presented a nurse practitioner appointment in the current model and the nurse practitioner was worried, they'd go straight into the GP, because that's the way they operate. And so that's no different into a neighbourhood access service. Clinicians are trained to work to their competencies. If they're not competent to do so, they will rapidly go into see a GP to see a GP in the way they do now. So this isn't about changing a model of care. This is about adding capacity to the model that we've got at the moment.
You're saying that you're not going to do any public consultation?
So no, I'm not saying that. No. So we will start the co-production piece. So if we've got a duty, you asked me if we've got a statutory duty to do public consultation. So at the moment, we don't believe we do need to do that. Because we're not necessarily changing. It's no different from acute respiratory hubs that we have at the moment in our services. But I'll take your point away and I'll double check with it.
Yeah, well, I would wholeheartedly say that if our practice was going to go that way, I would definitely want to have a say in it, and therefore I believe all other practices and patients should have that same ability. Yeah. I think it's very worrying, because you've admitted that this is about trying to keep people out of hospital. This actually is about cost saving in the end, not actually care.
So I think, to be fair, it really isn't about cost saving. If I go back to my bit about neighbourhood care and the understanding of neighbourhoods, hospitals are places where we can treat somebody, but they're not places where people get well. And we need to make sure that we provide services as close to home as possible so that people can adapt, can work things through. This is not about saving money. this may prove a benefit that the outcomes for people are better, which means we have less people going to A&E because we can provide more treatment to people closer to home. That is what it's focused on. Nothing else, not about trying to save money or anything else. It's an
it does ultimately save money because you don't have to provide more beds, and that's actually the data that you've said that you've got to produce from this innovative.
People don't do well in beds for a long time. The outcomes for people are poorer. We're trying to move to get outcomes for people to be better.
Can I just clarify the point? So the reason around the benefits realisation is because it's not about saving money out of the NHS, it's about transferring the money. So if we're going to invest in an additional 1,400 appointments a week in primary care, we need to get the money from somewhere. So we're not taking the money out of the system, we're just saying that actually the best place for a patient to be treated is actually not in an A&E department, it's actually at home, close to your GP as possible, and therefore we need to be able to facilitate and make that possible. GPs can't cope with the demand they've got at the moment. We see an overspill of patients going into all sorts of places and they're not getting the best care. This is about providing better care for patients as close as home as possible and shifting the resource around the system to facilitate that.
But you're not providing another 1,400 GP appointments, are you? You're transferring that into lower grade.
No, it's a mixture of both.
So where are you getting your GPs from?
So, well, there's a whole workforce strategy around this. So it's 2 years in the making. We've got a very good plan. We're working with the workforce teams around how we develop that. Look, we're stepping into a space that we don't, these are about innovation, it's about testing something new, testing something different. Some things will work, some things might not work, but patient safety is absolutely paramount in everything that we do.
Hence the duty, I believe, for public consultation, because that is exactly what is in the legislation if there is a change in the delivery of service.
Do you want to come in?
I do. I've got two questions, one for each of you. David, can I start with you? The trigger for me was the social prescribers piece on your slide. I represent a very rural community, and a lot of the things that you've talked about quite rightly have been where the density of population has been. But a lot of the issues are out there, they're just not as dense in the rural communities. So my question for you is, how are we wiring up the rural communities? Many of the people that you talk about don't have transport, the loneliness, the isolation, in some cases the rural poverty is extreme. And what are we doing to make sure that just because there aren't very many people in village A, they don't get missed? That's my first question.
Fine. Sorry. Thank you. I think absolutely we've got more work to do on it. One of the challenges, and one of the things that was quite helpful from Joe Morris was just flagging up what sounds to me to be like quite a small voluntary community organisation. We've been building networks with Voluntary Impact Northamptonshire and other organisations in order to be able to work out how to reach into small organisations. And it's small organisations that will make a difference. One of the things I'd say from an NHS perspective, but also from a local authority perspective, is things like village halls that hold a weekly cafe, breakfast cafe and a
community larders.
Those sorts of things will make a huge difference. What we all want to do is to have a look at how do we make that work. So there is more work to do. One of the things that something like Voluntary Impact Northamptonshire is good for us to do is we can have a conversation with them, they can have a conversation with 30 or 40 voluntary organisations. That's really helpful for us. We have done some other stuff before, and this could all develop in that way, where we have a mental health partnership in Northamptonshire, where about 9 mental health voluntary organisations came together and said, if you speak to us with one voice, we'll go away and sort out what we need to do. Those type of things have been incredibly helpful. So that's the concept. There's more to do to reach the particularly small organisations, but what we want to do is work in partnership with others to do that.
Thank you.
Thank you, David. May I just go to my second question? I've got a second question for Nikki. One of the things you talked about was the challenge of access to GPs. what data have you got about specific areas that have more problem with that than others? Is it a town centre issue? Is it a ward issue? Is it different parts of a particular area that has it? What's the data?
So we haven't got access to data which shows the number of patients that have been turned away by the GP practice, because we don't collect, the GPs don't collect. So if you ring up your GP practice and they say, I haven't got an appointment for you today, either call back the next day or you go off elsewhere, that's not recorded. So we don't really actually know what the true demand of general practice is in this county. Nobody, the country doesn't know in terms of where people, but what we do know is how many patients turn up in places like A&E. For care, which is primary care, for things that should be dealt with in primary care, and that's not a low number. You know, we're seeing patients turn up in all different places. I was talking to ambulance colleagues a couple of weeks ago, and they were describing a few case studies of patients where they've been out to see patients and not been able to get a patient in to see their GP practice. And we've talked about, well, what would that mean under the new model, under this way of working? How would we stop that from happening so you don't get patients that are suddenly escalated or transferred into hospital for care that they should be having in the community? And the whole idea of this model is try to build resilience in communities to be able to provide. So there'll be whole cohorts of patients that say, I only want to see my own GP in my own practice. That's absolutely fine. That's about the core contract. This is about buying extra capacity for patients. And there are lots of patients that actually just want to be seen. They're low complexity and would just sooner have an appointment, don't mind where they go, just want an appointment because it's better than going to A&E. That's what this service is designed to do. And if we can try and free up the time of some of the GPs then to do more complex care, long-term condition management, then that only has to be a good thing for patients, because at the moment, you know, we're seeing patients escalate into urgent care pathways when they shouldn't be, if we can just get the time and the space to be able to do some better management with those patients.
Yeah, this is desperately needed. Can you open tomorrow? I wish I had the capacity that those doctors apparently have, because you ring our doctors and you get screened by the, or triaged by the receptionist, or you have to go online and do it through the Anima thing. You can't get an appointment for love nor money. If you haven't rung in that first 30 seconds, you aren't getting an appointment. If you then go and ring it 111, they have appointments at your surgery, so perhaps if they hadn't got so many, you might be able to get in to see your doctor. I don't know how that works. But then, yes, you can't get in for love nor money. So somewhere that people could walk in a non-rural area would be fantastic. I should think a lot of people would be desperate for that, because you can't get to see your doctor for love.
Yeah, and we just...
Yes,
I was just going to say, you know, we are acutely aware that, you know, this, obviously we've tried to respond to some of the concerns that population and patients are coming to us with, trying to put the extra capacity in, but we are also acutely aware that we're only doing this in 2 neighbourhoods. And that does provide us with challenges equally, because we're aware, obviously, that 7 at the moment. I'll be watching the 2 in terms of innovation.
And also, yes, you're quite right, you triage from the bottom up. If you do get in to see somebody at whatever lower level, then if there is a problem, they escalate right up straight away.
To GP, and that would be the same. That would be the same in the neighbourhood access service. They'd be run by GPs, supported by advanced nurse practitioners.
Are you going to have this open at extended hours and weekends?
So at the moment, no. So it will be open in the normal GP hours, longer term. So if the concept works and the populations think it's a better service offer and we evaluate it, there is an opportunity to look at extending that longer term. But the GP out of hours service will continue as it is at the moment, but there's opportunities to kind of look at that in the future.
I would suggest that the cohort that you're looking at would benefit from some evening appointments, because your working population find it very difficult to actually get to a doctor at a suitable time. So it would be useful, again, if you consulted, maybe that would be something that would come out.
So the enhanced... The additional appointments in evenings and weekends is currently funded by the national contract. So that will continue. So that's still available and that will continue so. And there is opportunity for the neighbours to think about the model for delivering that alongside this model as well. So that exists.
Right, I'm keen that we keep moving, but we just need to pick up, are there any ways that we as a scrutiny committee can kind of assist in ensuring, I mean, to me, there are always issues about the health service understanding the voluntary sector and really working with voluntary sector. I kind of think there are always issues of different professional groups working together. And whether you're confident that this well, I think it will be an issue, and have you got mechanisms for dealing with those sort of professional boundary dispute issues, really? And is there an area that we as a committee could be useful in assisting this when it comes to an area that's identified, and just seeing whether we, our role here can be as assistance?
I think as a committee, you are already looking at social care, health and communities, and reinforcing that is really helpful. So I think while you as a committee will look at that, this is the stuff we want to change. So anywhere you can take those messages, if it's into full council meetings or into the conversations you have with officers' portfolio about the importance of us all working together, that's what will shift the culture.
Yes.
And that will really help us all make a difference in a way of working. So that connection stuff, I think, is really important.
Adrian.
Yeah, thanks, Chair. Could you get doctor surgeries to advertise that where it's available and when it's available? Because that would be helpful to stop breaking the doors down.
Once we know our 2 innovator sites, we will go rapidly into development with them and the community, because it's part of our service specification requirement of this is that the co-production with the community on that model is absolutely essential. So once we know that, I'm sure over the next 5 months it will become a lot more.
Right. I think it'd be very interesting if you could keep us informed of the progress and any issues that are coming up, and we'd be very happy to sort of deal with them.
Maybe we can have the information pack as well.
Oh, yeah. I mean, the slides that you're having, the slides we presented today, you will have.
Do you mean the neighbourhood packs?
I meant the neighbourhood pack.
Yeah, that'd be, Chloe, you're working, aren't you, with us on neighbourhood packs? Yeah, that'd be well.
We can have that as a committee.
Can we thank you for a really interesting presentation and wish you well as you move it forward, and hope that you get good, well, actually, it's not the good GP practices you want. It's all of them, and it's all of them. Yes.
And we hopefully for all 9 neighbourhoods longer term.
Excellent. Right, thank you very much. Okay. And that leads us on to our public health presentation. Moona, you've been sitting very patiently at the back. Would you like to address us for your 3 minutes on what your issues are that you want to talk to us about? So, Councillor Carley, yes, welcome.
Thank you very much for having me tonight. I'm basically talking about I'm reaching out about the health inequalities about our public sector. Did you know, actually, that there is, this is really, really dangerous to me, but there is comparisons that I've seen and done and looked up that between Northampton, there is a 76 years lives for men than women, than men in Brackley. So why is that? Like, there's so many questions, but I'll get to my point. I've bouncing off my wall here, but anyway. Basically, as I said, there is that comparisons, and there are no explanations to why this should be the case. We know also that there is that in Brackley, there's also the most affluent part of the council, and Castle, which I represent, the Castle Ward, is the least affluent, but there's no information beyond that about the cause of the early deaths amongst men in Castle Ward. So hopefully somebody could address that. The inequalities in West Northants are much greater than our usual between high and low income areas in Northampton or in the UK, perhaps. Is there a reason for that? Again, if not, you know, there is a need of research to find out what the cause of this terrible inequality is. I mean, is it down to occupational health, environmental health factors, or are there some weaknesses in the local health services? We know that there is a major problem with the COPD in shortage, lung disease in Northampton. Is this the problem in Castle? You know, this is the problem that we know and that we've figured out that is in Castle Ward. There are are there any proposed solutions? We opened a proposal for action to make sure that people in Castle Ward can expect to enjoy as long lives as possible or elsewhere in Northampton, West Northamptonshire. It's completely wrong that life expectancy in West Northampton should be postcode lottery.
Thank you, Muna. That is a really good challenge to present to us. And thank you. Chloe, any questions of Muna, or shall we go to Chloe's presentation? Because I think that will begin to resolve some. Yes, Adrian.
Thanks, Chair. Just a quick one, because we were hearing early on between the deprivation, health inequalities, and things like smoking, eating ultra-processed foods. You know, there's a lot more of that happening in Castle Ward than, say, the countryside. You know, that could be have an impact. You know, well, people spend their money on different items. Adrian,
shall we we'll okay. I think we'll let Chloe come up with the answers. I think our task is to ask the questions, really, and then to get the evidence. So, Chloe, thank you, Moon. A really important question for you to ask us.
Hi, thank you. So I was. It's interesting. I did have a slide on the drivers of inequalities, but I took it out because I was conscious of this meeting often is very long, and I didn't want to spend, because what I've done is presented what public health is here to do, and what each of the teams within the public health are focusing on. Health inequalities is under everybody's team's challenge, and so it's recognised as a challenge for all the teams, and I'll talk about that a bit more. But in terms of what drives inequalities, it's a very complex issue and it's very multifaceted. So we know that the conditions that people are born into, where they live, where they work, where they go to school, and where they age really impact on their outcomes that they have. And we know that people living in areas of deprivation, so poverty is a really big driver of all of those. So if you live in poverty, your life chances are limited. You live in poorer quality housing, you have a poorer education outcomes, poorer work opportunities, therefore lower income, and it's a cycle. But then that drives poorer health outcomes, because might not have the access to the services that you need or access to the information to live a healthier lifestyle. So we know that smoking is much higher in areas of deprivation, alongside some other groups as well. So people with quite complex needs, so like what we term inclusion health groups, so people with substance misuse, alcohol issues, people who are homeless, or people who sex work. Those people with very complicated lives often have much worse outcomes because of the circumstances that they're living in. So to address inequalities, we need to take a whole system. Like, everybody's got a role to play. Not one person can prevent that. We need to work as a council, as an integrated care system, to be thinking about how our services are designed to specific needs of different people, and that means tailoring services to different needs, but also how we're creating those conditions, those environments for people to thrive. So it's our housing, how we plan our environments, how we make sure people have got access to employment advice, people have got support to get out of poverty. So that is what public health is about. That's why we're here. We're here to really advocate for that. But it needs, everybody's got a role to play in public health, and that's why it's it's a complicated issue. So if you go on to my first slide, so just I just wanted to touch on the public health grant. So just acknowledging this new committee, wanted to start from the kind of basics, although I know some of you will have seen this. So public health is funded by the Department of Health and Social Care, and we receive a ring-fence grant each year. So our current grant is just under 22 million. A large proportion of that grant, so we've got grant conditions and things we have to spend it on, and that's on the next slide, but 61% of our grant is on block contracts for things that we have to do as a mandatory service. So that's our sexual health services, our drug and alcohol services, and our 0 to 19 services, which includes the Healthy Child programme that Maria mentioned. The rest of that is spent on other services. So if we go on to the next slide, so these are the things that we must provide, and then there's additional things that we have to provide. So as I said, sexual health, NHS health checks, which is around as a cardiovascular disease prevention programme, screening people who are otherwise healthy in the community to identify any signs or symptoms that they might have cardiovascular disease. Support for health protection, so emergency planning, outbreak management, pandemic preparedness. Working with NHS commissioners to provide public health advice, and the 0 to 19 programme, as I've mentioned. And then there's a list of other functions that we know are things that drive public health, so it's all the lifestyle behaviour issues and making sure we've got services there. And then there's as well as mental health, employment, and then there's a miscellaneous category which looks at those other factors that drive public health, which again are all about those creating the conditions for people to thrive and have healthy lives. If you go on to the next slide, please. So in terms of the key kind of strategy that we've got that informs our public health priorities is the Joint Health and Wellbeing Strategy, which sets out how we'll deliver the 10 Live Your Best Life ambitions. And again, these are absolutely informed by those drivers of health. And taking a life course approach, so looking at the health needs of children and young people and families, making sure people have got the right education, people have got opportunity to be fit, well and independent, and then looking at those conditions, so employment, housing, community safety, connections with friends and family, access to services, as well as those kind of more inequalities issues, so people who need a fresh start when things go wrong, so might have had complex or chaotic lives and need support, and also people feeling unaccepted and valued, so that's around community cohesion. So our strategy is about how do we create those environments for everyone to thrive, and how do we think about those drivers for inequalities and address those differences and outcomes. Next slide, please. So what is also important, sorry, you can't see that very well, but how do we embed prevention, and which again was been touched on several times today. We know that we need to prevent people from becoming unwell or having longer term needs across the life course. The more we can do and invest in that and keeping people well for longer, the better outcomes they're going to have and the better life experiences. So we've devised this kind of 4-tier layer of prevention. So the bottom two are about preventing people from having any issues at all. So that's our universal provision, keeping people well. So that's about promoting good mental well-being, about asset-based community development, empowering communities, our libraries, our contact centres, our leisure services, and parks and green spaces, all the things that we can do to create those healthy places. And that's, again, as a whole council, how can we do that and work together as much as possible? Level 2 is about intervening early, so identifying those risk factors. So, for example, our stop smoking services, healthy weight provision, getting people active, but also with debt and employment advice, screening, proactive support, working with the voluntary sector to support people in the community. And that's really where our local area partnership model is focusing on. And I know we've recently kind of had a review and a refresh and are relaunching that. Those meetings soon. The work's been still happening, but it's about how do we work in a local area to build those communities, to take an asset-based community development approach, working in partnership with members in the communities, our voluntary and community sector, to build those community assets like the ones we heard about, like the welcoming spaces. Level 3 and level 4 are for people who are starting to need services and starting to have more complex needs and need more joined up. So that's our adult social care services, Again, people who need debt advice, people who need physical and mental health services, adult social care, and how do we work in a more joined up way? So this is where the neighbourhood model comes in, and that's really exciting for us. I think anything that can help us work together in a more joined up and integrated way and meet people's needs holistically will really make an impact, and that's our kind of vision for prevention. Next slide, please. So on to our kind of public health portfolio and the priorities within each one. So we've got 4 portfolios in public health. So the first one is children and young people, all age mental health and oral health portfolio. So this one, again, working really closely with NHS colleagues on the Healthy Child Programme 0 to 19 services. So we've just recommissioned that service. How do we transform that service to improve outcomes, particularly focusing on the 2 to 2.5 year check, making sure people hit that school readiness target and making sure young people have a healthy weight. And then a link to that is working as a system. So our colleagues in children's services have just been leading on the development of a family help strategy, which is again is about prevention and early help for children, young people and families, and how can we support the delivery of that strategy. Also, we've got a target, and I know we touched on access to dentists with the health service. From a public health perspective, we're really focused on oral health promotion. So we have a statutory duty to do an oral health survey. So we're just about to do an oral health survey just to check, I can't remember what age group it is, but I think it's nursery age or 5 years, to check the condition of children's teeth. So it's physically doing a survey of people's teeth to look at what level of poor oral health have we got in the community and how can we put in place preventative approaches such as supervised toothbrushing and education around good oral health, because we know nationally one of the biggest drivers of admissions to hospital for children is tooth extraction. Also, we've got big priorities around mental health and learning disabilities. So we've just completed a joint strategic needs assessment on mental health across all ages, as well as a learning disability one. So there's a whole host of recommendations in there. So we need to develop the delivery plans for that. And that is part of the mental health and learning disability collaborative work, which again is a cross-system programme. We're refreshing our suicide prevention plan and have got some targeted campaigns going on at the moment, particularly focusing on men across the next few months. And then the inequalities one. So again, for all of these portfolios, we will always be championing where are the inequalities, who are the groups that have the worst outcomes, and how can we make sure we're addressing those. So some of the challenges, as I've said, is the inequalities for this portfolio. Access to dentists, which we've already touched on. So that isn't a public health responsibility, but obviously to improve oral health, that we need access to services to support people. And also ongoing challenges around the ICB. So, and as Maria touched on, the changes and the speed of transformation that's been expected of our colleagues in the ICB with the financial reductions, it will present a challenge in terms of some things will not be funded, or there'll be discussions about where funding sits. So I think that will be a challenge over the coming years. Next slide, please. So the Healthy Adults and Communities portfolio, so this is very much about the prevention and promoting and health improvement. So addressing lifestyle risk factors, promoting healthy ageing, reducing falls and frailty, building community resilience, so working with communities, that local area partnership approach. As well as within this portfolio, we're working closely with David and Nikki and colleagues on the integrated neighbourhood team model and how we develop that and make sure public health and prevention is part of that, and delivering the adults prevention strategy, which is the triangle I just referenced. So for this portfolio, some of the challenges are how do we embed prevention across the system? Again, I think there's absolute opportunities with integrated neighbourhood working and the new 10-year plan. Prevention is at the forefront of that, and it's really exciting to see. But I think it's how do we, because I think historically, again, I think David touched on it, things have been done very separately and seen as, well, you do that and we do that. And actually, it's how do we shift that to us all being owners of prevention, all recognising the role we've got to play. Again, the system changes, but I think absolutely for this portfolio, the new neighbourhood models, that integrated way of working presents an opportunity to embed prevention and more joined up working. The other challenge for this portfolio is just the rising levels of obesity, high rates of smoking in routine and manual workers, as I mentioned earlier, and our increasing older, frail population with multimorbidity. That is the challenge that we really need to focus on. But again, I think we've got the opportunity to really shift the dial on those. Next slide, please. So the third portfolio is looking at health harms, health intelligence and healthcare public health. So health harms is looking at drug and alcohol and gambling harms. So a priority for this area is, we're just going through a recommissioning process of our drug and alcohol services, and our absolute priority is to get more people into treatment and make sure people stay in treatment until they've completed treatment. That's the priority for that service. As well as we are aware of the increasing harms of gambling, and we recognise that we need to look at that and what we do around that. And also how we think about those people with complex needs, those inclusion health groups, and making sure we're championing their needs to make sure they're being able to access services to improve outcomes. The healthcare public health side, sorry if you go back, is that relationship with NHS, so NHS provision. So again, we've just launched a new sexual and reproductive health service. So how do we improve access to that and reduce STIs, HIV and unplanned pregnancy? How do we increase access to our NHS health programme? And in the last year, we've actually done a lot to improve uptake of that, but there's more we can do. And again, making sure that's built into pathways and using that opportunity to deliver preventative interventions. Improving screening for cancer, and again, understanding those inequalities in access. We know some groups are less likely to take up screening or access it, so how can we work with our colleagues at the ICB to address those inequities? Improving, we know that some populations just generally have poorer access to services. So again, how do we make sure we're using the data to inform colleagues who commission a whole range of health services about those needs and work with them to do more tailored, targeted work to improve access? And how do we embed prevention in healthcare pathways? So some of the big challenges, again, the changes for the NHS, ICB, it makes some of these areas quite challenging with the changes at the moment, but again, as I said, also presents opportunity. As I mentioned, rising harms from alcohol, gambling and drugs, so that's absolutely a priority for us. One of quite a specific challenge for NHS health checks is that a national digital model is coming out, so we need to make sure that is aligned with our local delivery and doesn't create inequities for people who are not able to use digital interventions, but it should go hand in hand in support. So ideally you'd want the digital one to be targeted at those who can access digital, and then we freeze up time for the face-to-face offer to be for those people who need face-to-face. Okay, next slide please. The final portfolio is healthy places and health protection. So as I said, health protection is infection prevention control, health hazard emergency planning and preparedness, as well as immunisation, particularly to prevent those infectious diseases. Healthy places is around those conditions, so employment, planning, housing, environment, poverty. And then also under this portfolio, we lead the anchor institutions work. So that's looking at how, as big organisations like local authority and NHS, we can have a positive impact on communities through what we put back into those communities as organisations. So some of the challenges with this portfolio is infection prevention control. It's one of the things that it's not clear in the NHS 10-year plan. They're talking about moving it from one to the other, and the guidance is still not very clear, so there is a risk at the moment that it isn't resourced adequately. So that's absolutely a priority for us to make sure we're having joined up conversations about that. We know there's inequalities in uptake of vaccinations, and again, that really came through in COVID. We know there are particular parts of the community who aren't engaging in that, and it's a priority for us to do some targeted work to improve that. Shaping healthy places, and again, I think you've touched on the kind of planning and how do we make sure public health and health is considered in planning decisions, and we're thinking about creating healthy environments. So if we're building lots of new houses, are we putting access to green spaces? Are we making sure there's opportunity for active travel? All those sorts of things. And I know we're working quite closely with planning colleagues to try and build that into the local plan, but there is always competing priorities, so the developer priorities are not necessarily the health priorities. So how do we address those? The crisis resilience funding, so that's a new funding pot that's coming out that's replacing the household support fund and another pot of money, so it combines the two. And again, we've had a lack of guidance other than that it's happening, so we just need to make sure that we're using that and to the best of our ability, and it continues to deliver the benefits that we've seen through the household support fund in addressing poverty. And the final challenge is pandemic preparedness. So we've got a big exercise coming up to look at our pandemic preparedness at the moment, but that requires a lot of system coordination. So it's just making sure that we are working effectively as a system. That's like, I think that's it. That's all of our slides.
About 3 slides ago, with the elderly population, I would add isolation down there, not just falls and whatever, representing a rural area. We have pockets of deprivation because people can't access services, and particularly with the elderly, reducing the impact of isolation would be an important factor on that list. I would add that.
Yeah, no, 100% it is, and it's part of our age-friendly communities programme, definitely.
Not much was talked about this evening about the massive reduction in budget from the Integrated Care Board, which we know is having a huge impact on them, and big changes going on and lots of redundancies, etc. Have you factored that in to how this is going to affect us and the services that we offer? Because obviously in some cases we work together with these things, and it will probably put more pressure on your services because there'll be a lack of services elsewhere.
Yeah, so we're having ongoing conversations with ICB colleagues. So at chief exec level, it's talked about a lot, and then for the relevant service areas. So, for example, children, young people, we're having in-depth discussions with Maria about that. So it is happening at exec level, but then also in the relevant portfolio areas as well to try and mitigate, because it is having big impacts, and it's how do we mitigate and work together to make sure that we're not seeing unintended consequences of some of the decisions.
Thanks, Chloe. You mentioned male suicide. Is there anything specific happening about youth suicide at the minute?
So we have a post-vention support package, a programme of work. So the team works really closely with schools. They've put together a whole resource. So if there's an incident or someone's identified as being at risk, that package will kind of be activated and put in support, and that's done in partnership with our education colleagues. So yes, we've got a whole strategy on suicide prevention. I think I just picked up the male one because there's a campaign coming out at the moment, but there's absolutely a full strategy which probably give you a bit more detail that we can share.
I'd like to add something to that, because 4 years ago when we first came in as councillors and we looked at the health data for suicide and self-harm was way over the national average in West Northants and in Northampton General. I just wonder what the figures are now, and hopefully that's part of the reason you're addressing it with this focus on suicide and self-harm.
I don't know the figures for that one off the top of my head, but absolutely you can go away and share them. But yeah, absolutely, that's why it's a priority.
I think it would be interesting for this, when we do that piece of work, it would be interesting, because I seem to think it was like 100% more. It was an enormous figure. It just leapt out at you that was something that was really important in this area.
Right. It's late in the evening, but your slide on prevention seems to me very important, and it seems to me very important that we as local authority, given our history, my sense is that we've got a tendency to work in silos, and it seems to me prevention is something you have to get out of silos in order to deal with it. And I mean, I think probably that we need as a probably as all the scrutiny groups to be doing, is to look at how do we get, how are we really innovative and creative in our prevention work that involves it involves all the partners we work with, but also within the council itself. And that would be something that the public health would have a real interest in, I would hope.
Yeah, absolutely. I think if anything we could do to really embed that prevention mindset and everybody recognising their role and how they can support with prevention would be good.
You talked about targeted work in communities where there's low uptake of vaccines, and also the concern of, obviously, in some communities there's lower uptake for screening for certain cancers. To me, it seems that there's probably a lack of trust in certain communities. So I think really a question would be, what is the council and what can we do as a committee to increase that? And I believe that education is very, very important, and obviously we're talking about adults, we're not talking about children, but there is a transition. Some of the councillors in this room are on the Children's and Education Housing Scrutiny Committee, and there's that bit in the middle that I'm very keen on building a link between, so so we don't miss out a lot of youngsters when they're adults at 18 and they haven't got support that they might have had in the schools. And I think that's a huge area we can look into. But really, my question is, what can we do, or what could we scrutinise really to change mindsets, to build trust amongst communities where there's inequalities, and also to build like a sense of trust with officers, sense of trust with people in healthcare, and sense of almost belonging, because it seems to me that when the trust goes and the sense of belonging, that's when people are isolated, and isolation, as we all are hearing and we all know, is what leads to ill health and inequalities.
Yeah, absolutely, and it really links to those. So two of the priorities in the Joint Health and Wellbeing Strategy, one is around feeling connected to friends and family, and one of them is around feeling valued for who you are, and that's absolutely about feeling sense of belonging, community cohesion, addressing stigma, discrimination in communities. So part of our work, and this is absolutely joint work with community colleagues in the communities team, it's that asset-based community development. How do we go into communities, understand their experiences, and work in partnership with them to build that community trust? And that's about also working with our voluntary and community sector colleagues. So I think a lot of it is about being in communities, being that trusted friend, being that trusted voice. And obviously, as officers, we can't all be there. And so it absolutely requires working in partnership with our colleagues in the voluntary and community sector to do that.
Right, I'm at the point where I want to begin to sum this up. I'm hoping that we can get two things out of Chloe's thing in terms of taking things forward. I think one thing is the prevention agenda, and how do we kind of get all our departments really bought into it, and what are the structures we need to make sure that is sort of embedded in the way we do things. The second is, I think, Hayley's point just now, because I'm interested. I wonder as a committee whether we have we can be part. I don't know whether it's our role to really do some work to convene different communities coming together and looking at what are the issues that are, what are the barriers to people being vaccinated. I think that's a very important issue. I'm forever getting texts saying, come in for this vaccine or that vaccine. And what's the take-up, and why do some people not take that up? But also about just generally accessing earlier care that people need, and just checking with all our communities that we've got everything in place to do that. So I don't know whether members here think that is something we should be kind of looking at. Yes, Rosie.
I think one area in public health that we should be looking at actually is the budget, because there are certain, I delved into it a little bit, and there are certain budgets that are very much ring-fenced by government, but there's also quite a chunk of money that could be spent more flexibly.
Right.
Because you've very much stated that we've worked in silos.
Yes.
And the prevention can sometimes be a much wider issue, where you might want to involve voluntary sector or like the people that we talked to earlier. The money might be better spent in a more appropriate area.
I'm thinking of, this might lead us into dangerous territory and beyond our remit, but I mean, there's an element of that that's about prevention work, so that if we're looking at prevention work, we're also looking at the money attached to it and the cost benefit of that, because I know some of the finance colleagues are wanting to be persuaded that prevention is cost effective, you know, so I think there's that bit. But the other bit of finance is actually looking at the issues in the adult services budget, and if we're moving towards a prevention approach, how does that work within that adult services area? You know, if we go further down the prevention road, will that produce benefits along the way, and how do we do that? And really understanding enough of our adult services budget to be able to do that. So I'm really quite keen that actually one of the things we do as Scrutiny is work with the finance scrutiny group to look at the adult services budget, so we really as a group of councillors at least really understand that. Because I don't at the moment. Right, Fiona, and then Hayley, and then oh, and Adrian as well. Right, quick fire, because we need to get onto the work programme.
Just to say that we don't rely heavily as much on the public health budget for funding a lot of things for the community and early help. We have a communities department, don't we, run by Vicky Rockall, that has a lot of funding that they give out to all of our charitable organisations. Personally, I feel that we should move forward into asking our charitable organisations to work with us more and do the things that we need to do, rather than, and this is not disparaging any charity at all, and obviously I'm a leader in the charitable organisation, I'm a board member of the VCSA, right. But if we were able to ask people to do the things that we needed them to do, the charities, that might be a better way of spending our money.
I think that's right. I think in our work programme we've got something about looking at the grants programme and how effective that is. So yes, Adrian.
Yeah, sorry. Can I just check we're getting the slides that we've just seen, and also because around that budget, did I say that about just over 60%? I'm not sure if that was ring fence, but that seems to be. I don't know if I'm taking a wild leap here. That's covering most of the problems that we're talking about, isn't it, with obesity and smoking and all the things that...
Yeah, so the public health grant is all ring-fenced, and we've got specific, it has to be addressing public health priorities. So it is those factors. So we've got our mandatory contracts that we have to fund, so 60% is drugs and alcohol, sexual health, and 0 to 19 services. And then the rest of it is on other public health priorities. So all the things that I've talked about, it funds all of those public health priorities. Yeah, but in there,
can that be some of the prevention that you're talking about, some of the money spent on that, because that seems to be a big issue.
I mean, that is prevention.
Yeah, I think my point or sort of proposal was very similar to Adrian's, and the chair said that there's some people that are not looking favourably on preventative measures, and we've also heard and agree as a committee that preventative measures are not necessarily spending huge amounts of money. They can on medication and whatnot, but they can be voluntary as well, as we heard about the hubs that are doing marvellous work. But really my point was really about you know, could we look at some of the figures in some of the interventions that are there that are just not working? So we could take the area of, say, youth suicide, youth anxiety as an area, and we could look at what interventions are there, and we could start to look at figures and see what's not necessarily working, and then, you know, look at proposing trials of preventative measures. Of course, we won't have data on that as yet, though.
Yeah. I mean, public health do that. Everything that we do is evaluated, and we are looking at effectiveness and value for money and whether it's working. So I think it's maybe you want to pick what you think is your priority area, and then we can come back and support you with a deep dive. But it'd be worth letting us know what your priority is, and we can let you know where we are with that, because some of it we might have already done that piece of work. So, for example, suicide, there's been a whole host of work, so it might be just we come and tell you and you're assured that we've done that, and then you decide you want to pick a different topic. But absolutely.
Thank you, Chloe, for a really useful presentation. I think that's kind of got our heads round the public health and given us some actually areas of work for us to take forward, really, which I think is really. And I do think prevention is whatever that is, and I think there's still issues that probably different people have different definitions of what prevention is. So I think we've got to do some work on really understanding that. But that is part of the task, I think. Right. So thank you for that, and I think that brings us far too late onto our work programme that's coming up. And Tracy, do you want to take us through where we are on the work programme, and we can all... Thank you.
Thank you. The work programme that's in your agenda pack reflects the outcomes of the informal meeting that you had on the 22nd of July. Neil Cox, the Director of Adult Social Care, has just got some small comments to make on it. In general, when referring to him, it should read Executive Director of People, in brackets DASS. In relation to priorities and challenges relating to the delivery of adult social care, Neil has commented, the Cabinet is understood to be working on a plan to outline their priorities. It would be helpful for Scrutiny to align the publication of this. In respect of outcomes of the Care Quality Commission inspection of the Council's adult social care function, Neil has said, based on feedback, this should be put in for December 2025, noting the committee has meetings on the 24th of November and 20th of January, so that would need to be scheduled in around that time. An adult social care workforce planning. This is a workforce board that meets regularly, so this item can be set whatever timing works for the committee. So obviously the committee will then make comments or questions that you've got on your draft work programme, but I know the chair is going to refer you to setting up a task and finish group as well. Yes,
I mean, I think I've got too many bits of paper in front of me at the moment. But not the right one. That's exactly what I want. So, I'm thinking that the health inequalities issue, that we could well set up a task and finish group to take the sort of challenge that Muna has given of very considerable disparities, and can we as a group better understand that, and can we kind of, I suppose, give some advice to the council about how do we... There's an issue that's almost too big to deal with, and it becomes, therefore we have a very amorphous response. I'm wondering whether we could actually come up with some really targeted actions that might actually make a difference. You know, we've got this huge health, you know, this data seems to suggest either the data is wrong, you know, and I think we need to check the data, but then to come up with some, I don't think the answer that we have to do everything is quite good enough. I think we need so what are the specifics as an authority that we could really engage with that will make a difference here? Maybe over a time, I don't know. Rosie?
I do have an issue with the focus always on inequalities, because you could spend the entire NHS budget on areas of inequality and you would probably move the dial by about 2 or 3 months, because you've got to start that this is people, you're looking at people who are dying 2 or 3 years before, you know, ahead of. You've got to have started at birth. It's 70 years worth of ill health, poverty, wrong food, all the other things that you know, people have mentioned, to just move that dial. And one of the things that I get upset about, or when particularly talking to health service people when they got to deal with the inequalities, how that just because we're from an area that's supposedly affluent, if you've got lung cancer or pancreatic cancer or you're diabetic, your health need is no less important just because you technically live in a supposedly wealthy area as opposed to not so wealthy area. I do understand the frustration. And I do think that there may be something you could do in terms of diagnostics in some of the areas where you've got the high deprivation. But I think also it links to the anti-poverty strategy group, which I'm not sure is still going or not, but that was also tackling similar aspects, because the two are very inexorably linked.
Fiona?
They gave you figures, facts and figures, and Muna really, you know, picked up on those facts and figures, but they do have the reasons behind those figures. So I think we need to ask for that information as to why these things, why they believe those things are happening from research that they've done already. Otherwise, we're doing work that they've already got in their cupboard.
I don't think we need to duplicate, but we might want to bring together what is known, and really, I'm into, are there some real targets that we can set?
I think this is linked to the prevention strategy.
Right.
And I think, to Councillor Herring's point, it doesn't matter where you live. If you've got lung cancer, you need support and help. But how we help people in different areas is going to be different. And if we call that health inequalities, that's fine. For me, we should be helping everybody, regardless of what their postcode is, based on the issues. And I think, for me, the best way to tackle this is through a prevention strategy, which will be very different in a town centre area to a rural ward.
Right. Okay, and I think we've got to tackle prevention across the different scrutiny groups. So it may be, we've got a triangulation meeting coming up, and perhaps I can take that to that. So perhaps we don't set up a group at this stage, and we look at how the triangulation meeting that Hayley and I will both be at, and we can represent the views here and see how we take that forward. Fine. Yes, Scott.
Thank you, Chair. Yeah, just building on that, I think we need to understand the reasons behind anything before we start properly getting into the reasons to scrutinise anything. So we should really understand why, and then we can move forward from there.
Right. So would you want something to come to, would we want to bring back some data to this committee to really ask for a kind of deep dive into that specific issue to come back to this committee?
There is also quite a bit of data on the work that's being done with the vaccination
Right.
situation as well.
Yes.
So I think rather than saying all those people didn't get vaccinated, I'm not going to tell you, but there are reasons why they didn't get vaccinated.
Yes.
And I think we need to see that too.
Right. Yes. Okay. That's useful. So you've got that right. What about our other priorities? We're still awaiting the community safety group. That's yes, and we're also looking at the grant funding thing that we're going to look at grant funding as well, and that's probably enough for us to be going on with at the moment, is it?
That will take us through into October.
Yes.
I'm also conscious about the scrutiny needed on the frameworks for the adult care. Is January a reasonable amount of time to see what's happened in the last sort of 6 months since it's come in? Is that
yes? Perhaps we'll talk.
As in what?
Yes.
As in what the situation is. How many referrals have there been? Have there any not been taken up by the people on the framework and that sort of thing? To get some facts and figures on it.
And then I think the new data system is now operating, and I think we have a whole additional level of kind of information that will produce that will mean that we can have a much more intelligent discussion than ever before, really. Yes.
The thing that I would encourage us to look at from a timely perspective is the domestic abuse strategy. If we don't do that in October, we're going to miss the White Ribbon campaign in November. So White Ribbon Day is 25th of November. We've got a scrutiny on the 24th of November. We shouldn't be leaving it until the 24th of November to scrutinise and be able to present to Cabinet, to full council on the White Ribbon campaign and domestic abuse. Domestic abuse is far, far too high in our area, and I think we need to be really getting to grips with what we are going to do to support that. It's down on the plan as TBC.
Right.
But from a timely perspective, I would encourage us to bring it forward.
That will be Vicky Rockall's team. They will be bringing the Community Safety Partnership annual report in October, so there'll be committees meeting anyway.
So we could look at both of those issues at that meeting. Yes. Excellent. Right. Rosie.
Yeah, I agree with that, but there is I would say it isn't just Vicky Rockall, but it's also housing, and Northamptonshire Partnership Homes also have an input into domestic abuse and support of their residents. So I was aware, and in fact the officers weren't aware that there were other people doing the same work, and it's one of those things where three different departments were all doing different things. So I'm just pointing it out because we need to make sure that it may have been solved by now, but at the time the officers did not know what the others were all involved in.
Well, I think that will be a good opportunity for us to make sure that that's so. I think one of our roles as a committee is to convene and to bring different aspect of services together, and it might be that we, if we're looking at that, I kind of think it's probably important that actually almost to invite the police, if we're having the different agencies along, that the police are invited to attend that as well, really, because we need to check that it's really joined up, and
Vicky will have the correct
contacts. Excellent. Right. It sounds like we've got a work programme ahead of us. Are people happy with that so far? And it's after 8:30. We're well into overtime. Can I thank you all for your attendance this evening and for your contributions to the meeting. We have a next meeting date in October, which is Tuesday the 14th of October. Again, thank you very much for your attendance. There be no further business. I declare the meeting closed at, 8:32.
I apologise for my lateness as
No,
well,
no.
but I was involved with waste.